Good afternoon, everyone. Again, I'm Gary Puckett. I'm president of the National Minority Quality Forum. Before we start our program, I want to share with you a new report that the National Minority Quality Forum is about to release. But before I tell you about the report, let me remind you about the way the National Minority Quality Forum is approaching things. We look at mitigating patient risk. We believe that every patient who comes into the American healthcare system, the system is operating to lower their risk. No patient expects the system to elevate their risk. And what that means for us, what that translates in, it means keeping them out of the hospital, emergency room visits, disability, mortality, while improving the quality of their life. But what it also means is that when we have new technologies and ways to intervene, we need to be expeditious in terms of making those new technologies available. The study that we're going to release this afternoon, and I hope you have a chance to look at it, it's looking at the role of late-stage cancer diagnosis in driving health disparities. When cancer is found and treated earlier, patients are more likely to survive. When we look at, there are only 5 cancers that have regular available screenings. But for the vast majority of cancers, we have no way of collecting them early. Minority populations are more often diagnosed in the latter stages of cancer compared to whites. And this late stage diagnosis is what contributes to the poor survival rates, the disparities in survival rates for minority populations. And so the trick of the matter is we need to get them diagnosed early to reduce patient risk and close this systemic gap. We must catch cancer earlier in minority populations. Luckily, new ways to detect more early cancers would have a disproportionate positive impact on minority communities. The new multi-cancer early detection tests offer opportunities to get a new screening tool into the hands of the medical community. But we need some policy changes in order to get there. Early detection guidelines that keep pace with advancements and reflection of minority and disadvantaged populations. Incentives that drive innovation in early detection and screening technologies. Coverage and access to early detection and screening technologies in private and public insurance plan. And fortunately, there's some legislation that is moving forward that, one, we need your help to make sure we can get it past the finish line, and that is the Medicare Multicancer Early Detection Screening Coverage Act. We also need better measures for assessing impact of early detection and screening in minority communities, and initiatives that promote community outreach and education. Early detection capabilities will affect the clinical landscape. And I really like this, because what it means is as these new technologies come on stream, we have an opportunity to study patients with earlier stages of cancer. We get better treatment options at earlier stages of cancer, and a greater understanding of how various cancers develop from early to late stage. So here's the website where you can go and view the paper. I'm going to ask them to put it in the chat so that you can click on it. We'll be working with our cancer working group to examine ways this new early detection technology can be maximized. And if anybody knows the National Minority Quality Forum, you know we're talking about doing it now. We're talking about how do we get this technology up and running in our community, because everyday loss means a life loss, and we want to make sure that we're not wasting time. And then we want to explore new research spurred on by advances in early detection. One of the things that I've learned as I've been following this early detection is that we have a chance to find cancer before it actually becomes symptomatic in patients. before it becomes symptomatic. What a place to be. And we think that it'll have profound impact on survival rates. So I want to thank you for allowing me to take this time. I'm going to turn it over to Mary and her team, but I look forward to partnering with you as we try to take this new technology and actually eliminate some disparities. So thank you so very much.
Thank you, Gary. That was great. And I hope everybody takes a note and sees that we're just a few minutes, behind our schedule, but with a really important message, I think, from our CEO. So I hope everyone has a chance to read that. I'd like to welcome you now, and I'm going to share my screen, and hopefully without any controversy, no technical delays. Hopefully everyone can see now. But welcome very much to our session, Taking Action for Equity Along the Cancer Continuum of Care. My name is Mary Murray. I'm the Vice President for Collaborative Action Networks here at NMQF, and I'm also the chair of our Cancer Working Group. We are really excited to have the opportunity to discuss not just the cancer continuum of care, but I think I want to copy some of the language that came from the video, but how can we each be a catalyst for this change so that we can just increase equity and quality of care for everyone and reduce disparities and improve outcomes. I'm Housekeeping Notes. I think you probably all know by now. If you have questions, we will have a Q&A shortly. Just put your questions in the Q&A and we'll try to get over to those. What do we mean by the cancer continuum of care? I wanted to make everyone aware that NMQF Cancer Working Group actually did a paper on this that was just published in January. And we've got 4 main domains that are in the cancer continuum of care: screening, as you just heard, and early detection, diagnosis, treatment, and survivorship. And so we know there's disparities all through there. Multiple stakeholders are involved and different populations have different needs. And so with our discussion today, we're going to use that framework, but I'm really excited to have a panel that is so representative of the many different stakeholders that it takes to develop and deliver quality cancer care. I'm excited to welcome Melvin Mann, who's a patient advocate and cancer survivor, Michael de Aguila from Grail, Population Health Sciences at Grail, Inc., Melissa Gonzalez in the Chief Diversity Office at Genentech, Edward Ford in Client Engagement at Medidata, and Dr. Robert Winn, the Director of the Massey Cancer Center at Virginia Commonwealth University. It's a real pleasure to have all of these panelists here today. The format that we're going to follow is each of our panelists will share about 5 minutes of opening remarks, and then we'll go into a moderated Q&A. And at that point, you can be entering your questions into the Q&A as well. And we'll just try to cover our topic that way. Without further ado, I'm going to ask Mel to start us off. But before I do that, I am also going to mention that Mel had a birthday 2 weeks ago. And if people feel the desire, please feel free to put some birthday wishes in the chat for Mel. I hope that after you hear his remarks and after this panel today, you'll really appreciate how remarkable it is to be saying happy birthday to Mel. So with that, Mel, I'm going to turn it over to you to please share your story and watch the chats. Watch the chat numbers rise. Oh, you're on mute, Mel. I'm going to go on mute and you go off mute.
Thank you very much, Mary. So my journey began 26 years ago. I was a 37-year-old major. I was stationed in Michigan with my wife and my 5-year-old daughter. And I had been experiencing back pain and fatigue. And I went to the doctor to get some results from some tests that I had taken. And the test revealed that I had CML, which is chronic myeloid leukemia. And the doctor further explained that with this diagnosis, I had a prognosis of 3 years to live. And he said the only possible chance at a better outcome or for a cure would be to have a bone marrow transplant. And being African American at that time in 1995, the previous year in 1994, only 8 out of 2,000 African Americans actually found a life-saving bone marrow donor. So my chances were pretty slim at finding a donor. But nevertheless, I decided that my daughter's 5. I wanted to see her grow up. So I started doing bone marrow drives, and I did bone marrow drives for the Army and also for the civilian sector. I was, like I said, stationed up in Michigan. And I did drives at colleges, churches, malls, you name it, wherever I could find an audience. And I just couldn't find a donor, and I kept doing this, drive after drive for about a year. And then I retired out of the Army, and I moved down to Atlanta, Georgia, to be closer to my wife's family in case something happened to me, as was predicted in 3 years. So it was about a year into my diagnosis. I moved down to Atlanta, Georgia. I kept doing drives, and my aunt arranged to drive down in Columbus, Georgia, which is 90 minutes south of Atlanta. And at that drive, a businessman came to the drive, and he said he had hairy cell leukemia, and he was near death, and he had tried this experimental treatment at MD Anderson, and it turned his leukemia around. And he suggested that I do the same thing. He had seen, like I said, the television promotion about to drive, and he came, and he was just being a patient advocate himself. And so I went out to MD Anderson, and I met the doctor. I flew out there. It's in Houston, Texas. And the doctor looked at my records and said, we still have time, even though this was 18 months after my diagnosis, my 3-year diagnosis. So he said, I'm going to put you on clinical trial after clinical trial until something works. So I started doing clinical trials and different combinations of drugs. And they would work for a minute, and then they would stop. And at the 3-year mark, I was pretty much at the same place I was at the 1 month mark. And I asked the doctor, I said, hey, is there anything else? And are there any more drugs? He said, well, we have one more drug. We're having problems in the lab with this drug, though. So, and the problems is in the livers of the animals. So I went back home, and about 8 months later, he called me and said, hey, we got approval to use this in humans for a phase 1 clinical trial. So I flew back out to Houston, and I was the second person to use the drug. And the drug was Gleevac. I used the drug, and it worked. It didn't work for the first guy in MD Anderson, but it worked for me. And it worked so well that about 8 months later, I ran a 26.2 mile marathon for the Leukemia and Lymphoma Society. And then I did a 111-mile century bike ride a few months later. And the drug, it took another 3 years for that drug to be approved. The drug was approved in 1998. I'm sorry, in 2001. I was diagnosed in 98. No, sorry, 95, 6 years before it was approved. So if I would have had to wait those extra 3 years, it would have been 3 years too late. So here I am, the world's longest living Gleevac patient and also TKI survivor. My daughter grew up. I saw her graduate high school. I saw her graduate Harvard College. I saw her graduate medical school. I saw her go on to residency and accept her first job as a psychiatrist. So I am Exhibit A of clinical trials. And it's just a pleasure to share my story with you. Thank you. And at this time, I'm going to pass it on to Michael.
Thank you so much, Mel. That's an inspiring story, and it's wonderful to hear that. It's fabulous. So thank you, Mary and NMQF, for the opportunity to be here today. My name is Michael de la Aguila, and I head up our Real World Evidence and Population Health Science group at Grail. As you know, at Grail, our focus is on cancer screening and early detection. And as Dr. Puckman was just saying, we've developed an innovative blood test that can screen for dozens of cancers, including many that don't currently have a screening test for today. And so our hope is that by complementing what exists in the current screening paradigm, the proportion of cancers that we can detect early will dramatically increase. And because this is a blood test, this will obviously benefit a number of patients, but we think that there will be perhaps an even greater increase in the ability for this to help the racial and ethnic minorities who, due to existing health inequities, are not getting access to screening as much as they could benefit from. And if we can just pause for a second and think about it in terms of like what's so much on everybody's mind right now, we know that COVID has taken about 600,000 people's lives here in the United States. Every year, 600,000 people die from cancer. And if you think about that, essentially 1 in 3 Americans have said, that they've lost somebody to COVID. That probably means that everybody, and all of us who are here, obviously, have been impacted by cancer, either personally or through somebody who we are very close to. And the simple fact of the matter is, even though we are making great progress in some of the treatments that are there, some of the same advancements and the same treatments that have existed for years are still being employed right now. We know that some of the diagnostics about survival, particularly if you're diagnosed, or the statistics of survival after diagnosis in late stage cancer are pretty sobering. So 2 out of 10 cancer patients will probably live 5 years or longer if they're diagnosed late stage. But if you're able to capture it earlier, then 9 out of 10 patients will survive for 5 years or even longer. So early detection, we know, leads to reduced treatment costs, it improves survival, and it improves quality of life. The thing is, right now we only have screening for 5 types of cancer. And so if we can augment that and identify a greater number of cancers, we have the ability to affect all of those that would be resulting in about 67% of cancer mortality in the United States right now. Innovation is critical for something like this. And innovation, as I was saying, can really have a disproportionate impact on racial and ethnic minorities, because these inequities do exist right now. And they start at the beginning of the cancer detection and then on through a cancer treatment, the entirety of the cancer care continuum. And so if we can identify cancers earlier in these minority populations, then it will have actually a disproportionate impact on their survival for the later stages. For example, right now we know that African Americans have the highest death rate and the shorter survival of any racial and ethnic group in the United States for most of the cancers that are around. Latinx communities are more likely to be diagnosed with advanced stages of disease as well. So quite simply, the vast majority of the cancers don't have screening right now, and they're contributing significantly to cancer mortality. So our goal is really to help shift the diagnosis earlier in time to have this pronounced impact on doing all of that. With a simple blood test, we think that this is a real opportunity for us to be able to do something like that. And as I said, because this complements our existing screenings, we think that it can increase the detection from the 16% of the cancers that are found through the existing screening tests today, and bring more people into screening because of the simplicity of a blood test, rather than something that requires a lot of specific equipment or specific testing procedures that are all for that. And it can extend it into rural and underserved communities as well. Obviously, to get something like this that is new and innovative covered and addressed appropriately, there's got to be a lot of policy work that accompanies it as well. And so we're excited to be working underway with some of the members of Congress to ensure that seniors in Medicare will also be able to have access to these new multi-cancer early detection tests when they're approved by the FDA. Now, obviously, we're very passionate about the new screening technologies and the capabilities that these offer, but we recognize this is truly the beginning of the treatment paradigm for people who have cancer. And so it's important that the same research innovation that's happening here be carried forward into the therapeutics and into the longer term care for these patients. And that's why it's a real privilege for me here today to be on the panel with some of the other experts that are presenting the exciting things that are happening from their perspective as well. And so because of that, I want to say thanks again for the opportunity to be here, and I'll turn it over to Melissa now and she can continue on.
Thank you, Michael. So thank you for having me here today. My name is Melissa Gonzalez. I'm a member of the Chief Diversity Office at Genentech. Now, the Chief Diversity Office has been at Genentech in existence for just over 1 year. So our Chief Diversity Office is unique in nature compared to most companies. We are not an HR function. The executive committee believes that we are a healthcare company and we are in science for all patients, for all communities. So they wanted a department that would focus on embedding diversity, equity, and inclusion across the business. That means everything from development all the way through commercialization. So we have, when Quita Highsmith was named our Chief Diversity Office, she was empowered to build a department and start developing key strategies on how to embed DE&I across the business. So the 3 strategies that we align to, or our 3 goals, are to foster belonging, to make sure that we are developing an inclusive culture where every employee feels empowered to come to the table, to share their perspective, and to be change makers, to boldly advance health equity issues for all patients. Our second strategy is around transforming society, making sure that we're doing our part to change the landscape out there when it comes to health equity issues. We're investing with partners that are looking into education around health equity, engaging with communities around these topics. And our corporate giving dollars have a very large focus on transforming society. Now, the pillar or the strategy that I spend most of my time working on is advancing inclusive research. This is our strategy to address the clinical research disparities that are out there impacting underserved communities, communities of color. Since we are a company that believes in developing personalized medicines for all patients, then we need all patients reflected in our clinical trials. So it's essential that we start working with development departments across our organizations and make sure that we're looking at some of the barriers at the systemic level, at the study sponsor level, and at the patient level, so that we can all figure out how to remove these barriers and bring more patients of color into clinical trials. This has been a really invigorating area to go into, and we're making sure we're making the right external partnerships. So we're not doing this in a silo, but we have colleagues from our external counsel, including Dr. Winn, helping us develop strategies to make sure that we're taking a holistic view to advancing inclusive research. So with that, let me pass it on to my fellow panelist, Edward.
Thank you so much, Melissa. And it's always great to hear from my fellow panelists about just their personal story and their professional journey. Allow me to add to that. My name is Edward Ford. I'm the Senior Director for Client Engagement at Medidata. Medidata is a Dassault Systems company. Our mission is simple: power smarter treatments and healthier people. Our platform, our technology platform for clinical trial development, helps our clients, our customers and partners, among them Genentech, do that. And we're just so thankful for to be able to do that. We take great inspiration from that mission. I take great inspiration from that mission as I joined Medidata to be able to pursue that. We take great inspiration from our clients. You heard a little bit about Genentech, for example, and their Office of Diversity and how they try to impact clinical development through the work that they're doing. We likewise do that as well. The inspiration for me, in addition to that, is also personal. And when the topic we're here today to talk a little bit about in terms of cancer is something that hits very close to home for me. As I look back, when I joined Medidata, I look back at my own family history and how cancer in particular has touched and shaped who I am and my family relationships. We heard a little bit about it in the video when Dr. Pucker was talking. I never met my grandmother. She died of leukemia. My grandfather, her husband, died when I was just a little boy, age 4, also of cancer. On my mom's side of the family, my grandfather died just a few years later. I remember him and his struggle with throat cancer. And then just last year, I lost my father to cancer as well. So as I think about just my own family, we've been touched to a great extent by cancer. It has taken those that we love from us. And so it only fuels my personal commitment to be able to advance and do whatever I can and whatever we can as a company to advance and bring folks together. This journey is not one that is just a solo mission where any one person or one organization is going to carry the torch forward, but really, and it's reflective in this panel, it's a joint community effort. We all must come together. We all must work together. And I think we're going to have a conversation about just that and how we do that effectively across a variety of dimensions. And diversity in clinical trials is a key aspect of that. And we'll get into that a little bit more later. As we move on, I'd like to hand it over to Dr. Winn.
Thank you so much. It is fun to be with this panel. I mean, they're outstanding and you've heard them. I think I'm going to break this down in the context of celebrating something that I'm excited about and that hopefully many of you know about, which is we're celebrating the 50th anniversary of the forming of NCI-designated cancer centers throughout the United States. Why is that important? 1971, they came up with the big idea of sort of saying, what happens if you partner NIH with academic medical centers? What would you get? Well, you get things like Gleevac. And you get through those partnerships, things like the immunocheckpoint inhibitors that we're using now. The challenge was back in 2019, when I became Cancer Center Director, at that point, we also have work to do. Of the 5,000 plus cancer centers in the country, only 71 are designated. So when I became and took the mantle here at VCU Massey, it dawned on me that in the 50 years, there had only been 2 African-American cancer center directors of NCI-designated cancer centers. It made no sense then, and it makes no sense now. However, what it gave us the opportunity, and this is why I love this panel that we see, gave us the opportunity to say, how do we reimagine what cancer centers can do over the next 50 years? And with that, one of the things that I think is central to both Ed's story, Michael, Melissa, and Mel, is that one of the things is we know that we can have miracle cures and miracle drugs and miracle tests and the most wonderful technology. But if people don't trust you, they ain't coming. Now look, what COVID did for us was a really nice lesson. And that it may be a warp done in warp speed and a miracle, but there's always going to be a sense of hesitancy. So why am I so excited? What you're hearing from this panel already is that we have 2 things that weren't actually here in 1971. Diversity, because as I told you, the very first 1971 on the War on Cancer actually had no women and certainly no minorities and no one interested in population health, nor did it have anyone from the community who led that charge. These next 50 years, that's different. You've just seen it for yourself. Second, another thing is different. We recognize now that to build trust, you must connect with the community. So there is now this wonderful bridging of the discovery, science, and technology, and the connection of that with the implementation health delivery sciences to our communities. I'm hopeful for the next 50 years. Not only because we have the new technology, not only because we have new drug discoveries, but because we have the awareness that really our communities matter. I think it was Theodore Roosevelt who said it first, and I got this quote from my grandmother, but she knew where it came from, Theodore Roosevelt. She says, Theodore Roosevelt once famously said, I don't know how much you know until, or people don't know or don't care how much you know until they know that you care. And if we're really going to talk about hesitancy, that not only applies to COVID, but it applies actually to the suspicious and sometimes outright distrust of the medical community. We have a big job to do for these next 50 years. It's not only discovering one-drop technology, it's not only coming up with a miracle drug, it's also having the grace and the humility to be not just engaged with our communities, but involved. There's great hope. And with that, I would tell you that I'm, as a cancer center director, not only the, in 2019, the only African-American cancer center director, now there's two. I hate being by myself. I ain't never been good with it. That's why I had to have my brother when I came along. I mean, ultimately, I would not be a good single child. I just wouldn't be. I am hopeful that as we move along this borders of thinking about how do we get technologies out into rural areas, how do we look at urban underserved, but more importantly, how do we actually, as we give big data and we get bigger and bigger and bigger data because that makes us feel good, that we don't inadvertently make our communities invisible. I personally think this is an exciting time. And I know we've been through some challenges, but I think we're waking up now, this new spring, if you will, of possibilities of bringing the discovery sciences and technology and integrating that full bore with our health delivery and making sure that our communities are always central. So with that, I'll stop because I would like to hear from this panel myself.
Thank you. Thank you all very much. And thank you, Dr. Winn, for leading us in with an optimistic, joyful viewpoint. As we were preparing for this panel, we were talking about those sort of four domains of the cancer continuum of care. And you've heard a little bit of them all here, screening. I have to look at my slide to make sure that I'm seeing everything, but screening to diagnosis, treatment, and, survivorship. And while there are activities we can each do within, each of those domains, we also talked about the transitions throughout those domains that patients need to go through. And so there's different interventions we can make along those cancer continuum of care, but we also, as we talked, some overarching themes came through as well, because the big thing is with any intervention, you're introducing a change, right? And so there are some themes that go with managing and implementing a change. And some of the themes that we'd like to focus the discussion around here today are myth busting. We came up with 4. Myth busting, gaining buy-in from stakeholders, innovation, and guidelines, clinical guidelines we wanted to talk a little bit about as well. So I want to start with the concept of myth busting. Melissa, you talked about starting a new function at Genentech that's only a year old and yet is reaching across the business to try to really build an equity lens into your entire business model. That sounds like a lot of change management required. Can you talk a little bit about the myths that you've had to bust, maybe particularly focusing on your area of advancing inclusive research?
Thanks, Mary. So busting myths is across the spectrum. But let me tell you about a trial that we recently ran. It was called the Impacta trial, evaluating Actemra in minority patients that had COVID-induced pneumonia. Now, why is this trial important? Because it busted the myth that, if you try to enroll more minorities, it takes longer, it takes extra work. This trial, we were able to set it up during a global pandemic, go to areas of the country where there were hotspots, where we knew communities of color were suffering disproportionately from COVID, and we're able to rapidly enroll. We had over 84% minorities enrolled in this clinical trial. Now, part of the reason that we were so successful is because we went to innovative sites. We went outside of some of the academic centers, went to community sites, safety net hospitals, areas where there was a high passion to really serve these communities that were suffering. And so the myth out there across a variety of different functions that, you can't, the patients don't trust research, you can't reach them. We busted that myth. This trial showed that when you go to the right places and you talk to the doctors and you make sure that you're providing access to treatments, the patients will enroll and they will, come to the table and ask the questions about how to get help with clinical research.
Thanks, Melissa. And I'm going to just take your point on patients will enroll and go to Mel. You talked about, you were on a bone marrow, seeking a bone marrow donor, and a patient saw that, came to you as an advocate and gave you advice to go to MD Anderson in a cancer clinical trial. Did you have myths in your mind about clinical trial? Had you been thinking about clinical trials, and what type of myth busting maybe occurred in you as a patient? And then what myths have you seen in your years as an advocate that you're able to help people overcome?
Well, that was never mentioned to me as an option.
Oh boy.
So that there's really no myths there. So when I went out to MD Anderson, when the doctor talked about clinical trials, that was, that offered hope for me. I saw that this is a chance for us to do something differently, because I knew even if I was on interferon, and this doctor was the doctor who had ran the clinical trials for interferon, so I had full confidence in him. And a lot of the myths are like, hey, there's not a lot of controls on clinical trials or whatever, but the myths that I dispute is that there are more controls during clinical trials. You're seeing more about a doctor. You almost, I was seeing like twice, 2 to 3 times as much on the clinical trial as I was just in the regular medical treatment. And also that you can get off a clinical trial if you want. You can start, you can get off. That's an option. And you don't always have to start in phase 1. You can start in phase 2, phase 3. So there's a lot of lack of awareness of education, exactly what happens in a clinical trial, and even the work that goes in a clinical trial before it reaches phase 1. So, I should have been the guy going. I should have been at 18 months. I should have been the one talking about clinical trials to somebody else, and I just took the mantle that the gentleman at my bone marrow drive, he handed off to me, and I just to continue to pass it forward. So that's my take on it.
Thank you. And I as you were all doing your opening remarks several times now, I've heard everybody talk about trust. And Edward, I think you have also talked about trust and data together. So I'm gonna sort of, still in keeping with this theme of myth busting, but almost taking myth busting over towards innovation. How, maybe I'll start with Edward, if you could expand a little bit on what you mean by the relationship between trust and data and how it can help us bust myths, but also lead to new innovations.
Sure. I think I was glad to hear Dr. Winn, say that in his opening remarks, and certainly something that we've seen. I'll go back. We did an internal event with our employees, and one of the things that we looked at was a walk through some of the historical basis. It was a Black History Month event. Some of the historical basis for why many African Americans are hesitant to engage in clinical trials in particular, but across the entirety of the healthcare system. And the fact that was actually rooted in experiences. And so we know about some of the more egregious and well publicized now instances of this, such as the Tuskegee experiment. But there is a long history of these types of violations that have impacted the understanding and the experience that many African Americans have had over the years with the healthcare system. And so that impacts, and having an understanding and a rooting in that, it allows you to understand why there is that distrust. And so when you can approach the situation and say, okay, there are some real perceptions here that folks have that we need to work through, you become automatically less dismissive of those. You become automatically more empathetic to how others, even if you don't necessarily share that perspective, how others are perceiving that. And that allows you to approach that with an opportunity to engender and build the trust that is necessary. In terms of data, I think the insights that we have across our industry, and certainly as a company at Medidata, to be able to look at and understand for clinical trials, are there sites that are performing particularly well? To look at data in real time and be able to make adjustments in the course of a clinical trial to ensure that there is accurate representation. These are the breakthroughs that we're seeing and working on today that provide great promise. We don't have to wait at the end and get a retrospective snapshot and a missed opportunity, because as we heard earlier in our intro, months matter, years matter, days matter. And so all this preponderance of data and the tools that we now have to analyze and to look at that data and to turn that around to be reactive in the moment, but also to be predictive, provides great opportunity for us as an industry to really impact the course of care and deliver better treatments, more effective treatments that we know are safe to the patients who need them.
Thanks, Edward. And I'm going to ask Dr. Winn, because you, Dr. Winn, you talked about trust and data as well. And your comment about data, I thought, was really interesting. We think of data as sort of illuminating a patient need, but you talked about the danger of big data, maybe making patients and populations invisible in the data. So I wondered if you could expand on that a little bit, and what do you see as the relationship between trust and data and advancing, innovation for treatments for everyone?
Thank you for that. Three quick things. First of all, no one would go and trust a doctor if you walked in their room or a healthcare provider and said, listen, I'm going to show you a CAT scan. It's not yours. The spot I'm about to show you about your lung cancer, well, it's not exactly in the same spot, but in general, we've taken 100 people and this is kind of what it looks like. You would say, what the hey? And yet when we actually present data, we don't present any type of precision or any type of personalized community data back to our communities. It says for example, in Chicago, 50 wards, when I was there, we would actually say, hey, we got data, ward is about 50 to 75,000 people. It made a difference to say, you know what, in your ward, in the 20th ward, you have 3 times more men dying from prostate cancer than the rest of the United States or in the rest of the state of Illinois. Now, what that did was it allowed for a different type of conversation. So I love all data, large and small. I mean, I have to be honest with you. Transparency's sake, as one of the first principal investigators for the Precision Medicine Initiative under the Obama administration, now called the All of Us program. So I believe in big data. But I think the march towards just bigger data, because it's more stable and it's all these other things that makes us feel it's more valid, we run the risk of aggregating so much that the very communities we say we're interested in, there's no real information about them. So I am a believer that big data matters, but I love all data, big and small. And I think that in the next, not only in the next 50 years should cancer centers change, but I think the way we actually collect data and our push for big data, we also should have a push for small area analyses as well. And second, measuring. Here's a myth that got busted. You answer what the myth? Here's a myth. You can't measure health equity activities. Get out. You're full of it. The truth of the matter is, with the NMQF now, ACS CAN and the NCCN, we all have now come in putting out what's called the health equity report card. I know I said it. If you can measure quality and you can measure safety, which people thought was impossible back then, but now it's standard, you can also measure health equity and you can measure health equity activity. So I think, again, my enthusiasm, I understand what we've just been through, but coming out of this, I am much more enthusiastic about what we can do. Again, if we have a little bit of the lessons learned and the grace and humility to sort of take, and the boldness to take some of these things, and the courage to take some of these things forward. So if people know their data, they're better able to trust their data. You say to Mr. Jones, this is your CAT scan, Mr. Johnson, Mr. Jones. You got this 2 weeks ago, you remember that. This spot on your left side, the left upper part of your lung, this is your spot, sir. And you show them the film, there's as a clinical physician, it's amazing, patient after patient, year after year. I'm amazed when you just show people this is what is going on with you and you let them into your world, the sticky factor and the motivation to say, what do I do, doc, is so much better. Just imagine if we were able to do that with our communities.
Thank you, Dr. Winn. I do see some questions coming into the Q&A. And Georgia, I'm going to get to your question in a second, but I want to bring Michael into the conversation as well, along the lines of myth busting, but also innovation and trust. You've got a new technology that has great promise, right? But yeah, how in the process of developing and using that technology, how does that relate to building trust? And how do you go about building trust for that technology? And also it's generating data, right, in a new way as well. So how is that going to add to the trust and data conversation?
Yeah, no, it's definitely a complicated thing. And to the extent that this is somewhat sort of paradigm shifting with regard to what we're talking about, you know, I think as a medical profession, we're, again, in our particular context here that we're talking about, we're really accustomed to screening for individual cancers. And what we're proposing now is this, again, paradigmatic shift to say, let's screen individuals for cancer and not be limited to just one. And that's a big idea to wrap your arms around for a provider, right? And so we have to recognize that we're introducing this new concept and earlier to a much broader array of providers who can now make access of this. It's a relatively simple process, right? It's a blood draw and the analysis of that. And to that extent, it might be a little bit easier for people to wrap their arms around the technology, so to speak, associated with doing this, which might overcome some of the barriers that patients would have with regard to their suspicion of some new technique or some new process, if they're able to get access to this in a much more ready and easy way. You could go out in a mobile van and do a blood draw with a phlebotomist and ship the kit off, get to many more people in a lot more disadvantaged areas more easily. But you need to have the providers be able to talk about what this really means to their patient. And just like Dr. Winn was saying, once you begin to understand the epidemiology and the distribution of these different cancers across all of these populations, it becomes a lot easier to frame that for the patients that you're dealing with. However, it also, if you think of where we are with our therapeutics right now, and we've necessarily tended to focus on later stage and more severe cancer, surgical efforts and things that are necessary under there, if we're bringing things earlier into the treatment paradigm, the stage progression of disease, we can begin to have innovative technologies that are developed to treat more effectively earlier on as well. And so we think that this could be a complementary means of, you know, looking at the screening and then developing the therapeutics that would be able to address a broader number of these cancers earlier in their stages to be able to achieve better quality of life and longer survival for these patients. It's important to recognize that we need to progress in a sort of standard way. So this new technology complements the existing screenings that are out there. But at some point in time, as the profession, the community, and the technology becomes a little bit more solidified, we think that this really could transform the way that the care is provided in a manner that would be much more equitable to these larger populations.
Thank you. I have more questions here, but I don't want to keep Georgia waiting. I'm going to paraphrase your question a little bit, Georgia, but she'd like us to comment on really funding for research and how does money relate to trust? You know, I will read her exact question. If we follow the money, how do we get the community to trust the funding source if it's different from government support of a clinical trial, such as Tuskegee, something like that? What's the relationship? And how do we talk to people about who's funding research and how that might impact their trust level? Looking to see who's most open. Dr. Winn, you're talking, so you go first.
You know, I will say that that's a great question because I think what I've also learned is because there's so much misinformation these days, disinformation, there's also increased suspicion. And so I think to your point about being a savvy person in the context of where the money goes is exactly where does the money come from and what do they want with it? So I think that this is where we also have our partnerships that matter. I think that when you have a big pharma university partnership with the NIH and other partnerships with academic and big pharma, I think that in general, there are standards. I always look at not where the money comes from, but where the money comes from and what are the guidelines and bumper guards that they have to do business. At the NIH, there's certainly bumper guards. And in fact, they're, mostly transparent. So I think that can be said now also with many companies and many other programs that are actually starting to do things, that the old the Mad Men sort of era is gone. The back room where, back then with cigars and all the rest of that, nobody does that. It's an old school way of doing it. I think so that more big companies, and Melissa and others can talk about this, and Michael can talk about this, but I think that transparency has been the name of the day for many of our companies in the context of us moving forward. And I think that we'll have to do an even better job in transparency to gain trust. That's probably what I would say.
Thanks, Dr. And Melissa, would you comment too? Thank you.
Yeah, and I think it's also, I agree with everything Dr. Winn said, and presenting the info in a manner that patients can understand, right? We've been talking about informed consents in clinical trials. When it comes to data, a lot of patients wonder, who has access to my data? Is this going to go to the government? Is it going to go to immigration if I'm Latino? What does this mean? And another, I think it's on us across the industry to make sure that we're giving the right information in an approachable manner so that patients can say, oh, they wrote this so that I can understand. They're not trying to talk above my head. They're coming to a level that will resonate with me. So we have patient letters now that, you can, if you have a question, you can call in and ask for a patient letter. We know NCCN now has patient guidelines. So I think it's just on all of us to make sure that when we know patients are now looking for more information, let's make sure we're delivering it in an approachable manner.
Thanks. We have another question in the chat, sort of diving in on that. What are the strategies to help identify and engage people like Mel who may be a candidate for a therapy or a trial and may be willing to engage and participate, but who don't have the connection or awareness of the opportunities that exist? How does industry see these unseen or easily overlooked individuals and communities? Why don't we start with Melissa, if you wouldn't mind picking up, and then maybe Edward, because of the visibility you have across industry.
Having the right external partnerships, working with people in the community that have the heart and the ear of the community, because they trust those people. So when you work with them, and then you need to listen, what will resonate, what is not resonating, what do we need to fix? So only by working with the right people, listening, and then responding can we really start to reach more patients across the community, more referring physicians. Because, as has been pointed out, is if you're only talking to the research oncologists, you're missing the bigger ecosystem, because oftentimes we know patients don't get to the oncologist in time to hear about a clinical trial. So think about the journey, just like we're talking about today, and who are those touch points that we need to be engaging with?
Thanks. Edward?
Yeah, Melissa, I think you're absolutely spot on there. I think that the relationships are a critical piece of this. I saw in the video that preceded our section, Dr. Fabian Sandoval, and as a provider, he runs the Emerson Clinical Research Institute just outside of Washington, D.C., or in Washington, D.C., I should say. And so, we've enjoyed a great partnership with him. I know Genentech has as well, and supporting him as he's worked to build inroads within his community, within the Latinx community, to raise awareness around a myriad of health issues, but also specifically around the importance of participation in clinical trials. And so we've supported him, and not just supported him in saying, let's meet with him. I mean, dollars, right? So he actually has a television show called Tu Salud Tu Familia. And we've been fortunate enough to be a founding sponsor with him. A few months ago, we were all celebrating. The show won an Emmy Award. And so these are examples where he's raising awareness. He's a credible voice among his community. And so being able to support that journey on an ongoing basis is critical, which leads me to the kind of second point before I turn it back to you, Mary, is, and I think this goes for the previous question about the money. I think it's important for all of us to understand we can't just show up when we need something. If you relate it to kind of personal relationships, you have those people in your orbit that only show up, they need something. Let me hold $20. I need you to come and drive me to the air, whatever it is. Those relationships are not productive. And so if you transpose that thinking onto an organization, onto engagement, you need to be there and be part of the conversation, even when you don't need anything. We just coming through COVID, many of us may be working from home. It's always nice to get that text message or that ping. Hey, how are you doing? Just checking in. Don't need anything, just want to see if you're okay. Those are the little small acts that engender trust. And if we as organizations, wherever we sit, sponsor, doctors, technology providers, if we can do that, if we can show that we want to be present and we want to make sure that you're okay without anything self-interested, it grows that trust. And so then when we need to actually partner to do something, there's a foundation already there to facilitate that.
Well, so that's I think probably a mind shift in investment as well, in investing in communities, and how can industry partner with the community to make those investments that show the commitment that we've got. Michael, we haven't heard from you in a bit, and I want to bring us around towards, when you've got something like a new technology, like you're talking about early detection, then what we talked about in planning for this was the relationship between the early detection technologies and the innovation in the treatment landscape that needs to come along with it. If you've got earlier stage diagnosis, you need treatments that are viable for earlier stage cancers as well. And I wonder if you could talk a little bit about that, how you see those pieces working together. And then Dr. Winn, I'm going to ask you to finish on how the evolving treatments play into evolving guidelines. So just to give everybody a little heads up where we're going with this.
Sure. Yeah. No, and that, the point that you're making and the question raised is really an important one. And I was touching on it a little bit earlier, but clearly this is, if you will, the tip of the spear, whatever the metaphor you want to use is in terms of identification, but it has to be accompanied by appropriate treatment. And we're already talking about the recognition that, as Dr. Winn said earlier, the treatments are there, but if people can't get access to them, what good does it do? And it's a similar sort of a thing of, if you can identify these new cancers, but there aren't treatments, then what good does identifying them do as well? And so we are keenly interested both in acknowledging that there's a great opportunity here, whereas before, current screening techniques don't necessarily identify a whole panoply of these cancers. The test that we have at Grail identifies up to 50 different types of cancer, right? And so you want to be able to say, if we're identifying these a little bit earlier, we want to first and foremost, work to focus on those that really are meaningful with regard to treatment. Frankly, not all cancers need to be treated with the same level of urgency, particularly depending on the stage for all of that. But working with our partners on the therapeutic side to engage in research, you think of things like companion diagnostics or companion identifiers now, to be able to create these synergies to understand, okay, if we have this new technology to identify these cancers, let's work to develop the therapeutics that can manage them. And it becomes, from the treatment side, the healthcare delivery side, a focused effort that spans across the continuum of the cancer care that we're trying to support ourselves. So we're interested in working in partnerships with organizations that are developing new therapeutics and doing these kinds of things, but at the same time, working in the communities that would best benefit from having access to these new therapies as well. The simple way of thinking about this is innovation in one sphere drives innovation in another sphere.
Thank you, Michael. And then if Dr. Winn, if you could say, how does that innovation help to drive the evolution of the clinical guidelines?
Yeah, I mean, they go hand in hand. I think that, I mean, who could ever think that we would be doing things around immunotherapy, right? I mean, or who would ever thought that, you know, we would even have technologies that could be really a one drop sort of thing. So all of these things go hand in hand. And as we get these big miracle technologies on, I'm actually telling you right now that within 10 to 15 years, we're going to be thinking about things that we have no idea of how to even talk about right now, but that will require guidelines. Guidelines are the following, not just on the administration and blocking and tackling, but guidelines about how people are told and informed about them, how we actually re-instruct people about, you know, maybe some of the side effects. What we've learned, actually, I think if nothing else from COVID, is that being clear and not actually just having what I call science speak is important to people. How we enroll people on clinical trials will maybe potentially even look different. Look, one of the coolest things about clinical trials is we used to talk about a lot of inpatient and all the rest. Imagine a day where most of the stuff now is happening as an outpatient. Or even, I know this is gonna sound crazy, but imagine it's things happening in your community that, yeah, instead of having to go across town to the MD Andersons or the Massey Cancer Centers, we can set up your NCORPs right in your neighborhoods, and we can do most of these trials. That's gonna require some guideline shifting and changing and thinking. And so again, I mean, if I sound optimistic, I'm unapologetic about it because I am. I think that there is a lot of reason for cautious optimism, and obviously pragmatism will get us there. But as it comes to these new innovative drugs and technologies, things are going to change. Imagine 30 years ago, could you imagine getting your own EKG off of your cell phone? Let alone with the right transducer diagnosing your own kidney stone. What are we going to do with that? So we are just scratching the surface of new breakthroughs that I think are going to change the way in which science and the community sort of interact. And with that, I think we are going to be thinking about different types of guideline changes as we evolve. So that's my short answer.
Thank you very much. Well, we really have just 1 minute left. I want to share my screen again because I had asked everyone to, and I don't have it in slideshow mode, I'm not going to go there. But we had asked everyone, you know, what do you want to leave the audience with? So we have kind of those key messages here, and this deck we can share when the recording goes out of the session. But I think the important thing to leave folks with is that, I'm going to paraphrase President Obama here, we are the change we seek. And so it's important for each of us as individuals and within our organizations to know that there are actions we take right now to build equity into this process along the cancer continuum of care, all of the things we've been talking about. And sometimes folks don't know the next steps. So we borrowed a framework from Dr. Wingfield and her article on why racial justice matters in radiation oncology. It's called LEADS, which inspires us all with activities around learning, engaging, advocating, defending, and supporting. So we just listed a few here to give you all some ideas what to do next. What could your next step be? And then to help you along there, we also have a bit of a reading list and some additional resources as well, not the least of which is NMQF's Diverse Cancer Communities Working Group. We really invite you all to join us in that. And so you can contact me with questions about that. So we're right up against time. I really just want to give my heartfelt thanks to all of our panelists. I hope that having all these different stakeholder perspectives is really helpful to our audience in understanding how to make big change in this area and improve cancer care for everybody. Thank you all.
Mary, what a beautiful, diverse panel that shows that we are here and we are representing the people. So thank you for the opportunity.
Thank you very much.